This is Victoria Lancy from the Michigan Center for Rural Health. We're going to go ahead and get started. Good afternoon, everybody. As I said before, my name is Victoria Lancy, and I'm the Rural Education Manager with Michigan Center for Rural Health, and will be facilitating this program. I would like to welcome everyone to today's Legal Grand Rounds on Rural Ride-Sharing Providing Patient Transportation Assistance, which is brought to you by Hall, Render, Killian, Heath, and Lyman, and the Michigan Center for Rural Health. Before we begin, just a couple of reminders. If you are logged into the webinar portion and have computer speakers, you can listen to the audio through them. If you are listening to the program through the audio number provided, handouts are located on our website. Our website is www.mcrh.msu.edu. Click on the education link across the top, scroll down, find today's date, and there you will see the presentation and the evaluation link. The evaluation must be completed online, and please complete this within 2 weeks or by September 7th. It helps us plan future legal grand rounds for you. If you would like to ask a question during the program, please type it into the chat box so you don't forget it, and the presenter will address it during the Q&A. Our presenter today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program. With that, I am pleased to introduce our speaker, Brian Bauer, who is a shareholder in the law firm of Hall, Render, Killian, Heath, and Lyman, and has over 20 years of experience in health law. Go ahead and take it away, Brian.
Well, thanks, Victoria, and good afternoon, everyone. It's a pleasure to be here, and I want to thank the Center for inviting me to participate. The topic we're going to cover today is rural ride sharing. Over the years, there's always been interest in assisting patients to get where they need, and I think, I don't know if it's just coincidence, but I've heard more of those questions in the last couple of years. More stories about where there's needs to assist patients to get where they need to go for their health care. So with that, let me just get started. Roughly a year ago, we got regulations coming out of the OIG with regards to transportation services. I think I probably had mentioned at one of my presentations that we actually had proposed regs addressing this a couple of years ago, probably, well, maybe as long as 2013, 2014. And they just kind of languished there as proposed regs, which gave us an indication of what the OIG was thinking, but really didn't provide us any safe harbor. And so we actually got the changes last December, and they released a final rule codifying the new local transportation safe harbor. Now, I think it's important to kind of tease apart the different statutes and regulations that we usually deal with along this. So this is a safe harbor for the anti-kickback statute, and it is a safe harbor for the civil monetary penalty statute. It is not a safe harbor for Stark or an exception for Stark. So we need to keep that in mind. I'll address that a little bit more a little bit later. But the really cool thing is, the great thing is, the OIG has actually provided us a safe harbor. The civil monetary penalty statute, I said it's a safe harbor for that, but I probably ought to give a little refresher as to what the CMP law talks about. And that, it covers a number of issues, but one of the ones that is probably the most common is it makes illegal the offering or giving of anything of value to a patient with the intent of having or inducing that patient receive services from a particular provider. So you can see where the provision of free or discounted transportation might induce or be seen as inducing a patient to receive services from a particular provider. So this gives us a safe harbor. We don't have to worry about, as long as we meet the requirements outlined in the reg, we don't need to worry about violating the kickback statute or the civil monetary penalty statute, as long as we're within these specific requirements. So the first thing is an eligible entity, and one of the great things in this case is the OIG was very broad in defining eligible entities. So it includes the individuals or the entities that we would typically be concerned about, physicians and hospitals primarily, but it goes on and covers physical therapists, dialysis, easy for me to say, dialysis facilities, home care agencies and entities, and so we've got a very broad definition. I mean, it even goes so far as to include non-typical healthcare providers, such as managed care organizations. So an eligible entity's really got a pretty broad definition, and I would guess that 99% of the folks on the call would be covered. It may be as high as 100%. So I think that's important. The transportation must be for the delivery of medically necessary services. It may sound a little silly, but the government, CMS and the OIG, in a lot of their regulatory or what I typically refer to as preamble or explanation language that you'll see in rules and regs, they often talk in terms of providing transportation to sporting events or entertainment events. They seem to be worried that somehow this is going to be used as an improper inducement. So one of the ways they've made it clear that to be qualified for the safe harbor, it's got to be for the delivery of medically necessary services. I think that's all we're all focused on anyways. So it may seem a little obvious that that's what it would be for, but that is one of the specific criteria. And so I think, and we'll take questions at the end, but so I think it's clear, or I should make clear, that it's not really intended to provide services like somebody has to go to the grocery store. I don't think that would be covered. But to get to a physician appointment, to get to the pharmacy, to get to a PT appointment, that's going to be covered. It's going to be related to medically necessary services. It also must be for an established patient. With the proposed rules from a few years ago, that meant it had to be with somebody who had already received services from the provider. Under the final rule, they broadened that a little bit, which is great. So an established patient is defined to encompass both a returning patient, what I would typically think of as an established patient, but it also includes any patient who's made an initial appointment. So you can't advertise these services. You can't say to somebody who's not a patient, hey, we can provide you transportation. But once the patient has made an appointment, even if they've not yet seen the physician, so if they call the physician's office and say, you know, gee, I want to make an appointment, schedule an appointment. The reason I want to schedule the appointment on this date is because I've got transportation issues, and my daughter, that's her day off of work, so I always have to have my appointments on a Thursday. At that point, the eligible entity, the provider, would be able to say, hey, we offer transportation services, so if Thursdays aren't the best day for you, we can help you with getting to your appointment, even if your daughter's not available. So they broadened that definition of the established patient, which again I think is a real big plus, real big help. So the transportation has to be local transportation. Under the safe harbor, local transportation means 25 miles if you're in an urban area, or 50 miles if the individual resides, and this is the patient, resides in a rural area. So we get a little for those, which probably are for the most part going to be all of us, we're in a rural area. Now, how is it defined? What are the specifics? How do we know if we're rural or not? Well, CMS always makes it pretty clean. If you're in a metropolitan statistical area, you're in an urban area. I mean, it also covers New England metropolitan county areas, but that doesn't obviously that doesn't apply to us. So in Michigan, if you're in a metropolitan statistical area, you're urban. If you're outside of a MSA, you're rural. Now we do have some reclassification for those of you that are critical access hospitals. Some of you know that your areas have been reclassified from rural when you first became a critical access hospital, and then they, based on the census data, CMS has updated it, and you're now in an urban area. You know, I think, although I haven't yet specifically looked at that question, but I think if you've been reclassified as urban, we may be able to make it 50 miles for you as well. I just thought of that while I was presenting, and maybe I should have thought of it before I presented with you that have been reclassified over the years. But the general rule is, if you're in an MSA, you can provide 25 miles of transportation. If you're outside an MSA, you're rural and you can go 50. Mileage is measured in this case as the crow flies. So for all of those of you that have always, that have been looking at the mileage issues in connection with critical access hospitals or off-campus provider-based locations, you know that you often, do the MapQuest and look at mileage and, how many miles on primary roads, how many miles on secondary roads. That's not how it's done for the purposes of this safe harbor. It's as the crow flies. So you put a pin in your location and draw a circle around it, 25 miles if you're urban, 50 miles if you're rural. That's where, that's the extent of the boundary. Now, the regs talk in terms, and CMS and the OIG in their boy, I cannot talk today, I apologize. In their description and explanation language, the preamble language, talks in terms of this being a bright line test, which is easy to apply. Well, I think that's always a little misleading. For one thing, we'll talk about Stark in a minute, which I think makes it a little less bright line. But the question I always get, and I probably will get again, is, well, what happens if we're in a rural area and it's 50 miles, 50.1 miles? Well, the answer is, the specific answer is, you're outside the safe harbor, so there is risk if you take that and pick up a patient at 50.1 miles. Is it great risk? No, probably not. Well, if I can do 50.1, can I do 52 miles? Can I do 60 miles? Can I do 61.1 miles? Well, as soon as you get outside that 50 mile or 25 miles, if you're in an urban area, you're outside the requirements of the safe harbor. The safe harbor, if you meet all the qualifications, the OIG, the whole concept of the safe harbor is, if you meet all those qualifications exactly, the OIG will not take any action, will not prosecute matters if you meet all the requirements. Well, as soon as you go outside 50, even if it's 50.1 miles, you're outside the specifics of the safe harbor, so there is additional risk. I don't tend to think of it as a lot of additional risk, but some of it depends on the surrounding facts and circumstances. For instance, if you're in an area, somewhere, maybe in the UP, and then there is another facility for another 60 or 70 miles, well, if you go to 50.1 miles, I'm less concerned that if your facility is only 14 miles from the next hospital and you go out 50.1 miles, and that happens to be on the opposite side, the far side of another hospital or provider. Then it looks like you're not doing it for the sake of making sure that the patient receives needed healthcare services. It looks more like you're trying, from a competitive point of view, to take patients away from a competitor. So I think if you're going to be safe, you're going to stay within the 50 miles. If you're going to go outside the 50 miles, the further outside you get, the greater the risk and the circumstances. If your 50-mile circle overlaps with another provider's 50-mile circle, you have greater risk if you go beyond the 50 miles at all than if you're in a situation where there's no other provider within your 50-mile circle, or there's another provider and their 50-mile circle is still beyond your 50 miles. So it's just important. I know it says it's a bright line test, and in one sense it is, because as long as you stay in your 50 miles, even if another provider's circle of 50 miles overlaps yours, as long as you're in your 50 miles and you meet the other requirements, you're going to be within the safe harbor and you're going to be safe from prosecution by the OIG. As soon as you get outside your 50 miles, there is increased risk. The safe harbor protects transportation to and from the hospital or other eligible entity. It's basically to and from the patient's home to the care, or it could be from one eligible entity to another eligible entity. It's 50 miles one way. It's not round trip. So as long as it's involving transportation for medically necessary services, you're going to be fine. And you stay within, obviously, the mileage requirement. Transportation doesn't have to be planned in advance. It's one of those things, patients scheduled to come see your provider, and their daughter was going to bring them, but the daughter got sick, got called into work, something came up, the daughter couldn't make it, patient calls and says, hey, I got to cancel. No, you don't. We can send the transportation van or whatever the transportation arrangement is. We can provide that. So it doesn't have to be planned in advance. It can just be on an as-needed basis. Eligible entities wanting to provide beneficial low-risk transportation arrangements that are outside the safe harbor should consult their legal counsel. I probably should drop that bullet point. It sounds too self-serving. But it is important that if you are meeting all the requirements of the safe harbor, you're safe. But as soon as you get outside and don't meet any one of those requirements, none of the safe harbor applies to you. So it is important just to make sure you check with your legal counsel so that they can advise you on the risk that might be involved. Marketing limitations, and this is usually an area where I get a lot of questions. Transportation assistance cannot be publicly advertised or marketed to patients or others who are potential referral sources. So you can't use this as a marketing tool. If you have a patient who says, hey, I want to come to you, but I have transportation issues, well, then I think that's a little different. But you cannot be marketing it, can't be advertising it. I wouldn't have a poster up in your physician offices saying, hey, we can provide you with transportation services. No, I don't think that is a wise sort of process. I think the best way to communicate the information about the transportation services is by the clinician. by a care manager or a discharge planner, somebody who's talking to the patient about clinical issues. Certainly your receptionist can do it. If the patient calls in again and makes an appointment, and there's a discussion about transportation, you can certainly have that conversation. But you can't be advertising. You can obviously, the third bullet point talks about this, you can have signage on your van if that's how you're providing transportation. But you can't have billboards saying, hey, we have a van. I mean, you want to have the signage on the van, so when a strange van pulls up in a patient's driveway, we don't have patients just getting into strange unmarked vans. So you can clearly have the signage. That's on the van, and if it happens to be driving through town and so people see it, that's fine. But you can't actively use it as a marketing tool. No marketing of healthcare services or items can occur during the transportation. I was recently in New York, and I was taking a cab, and every one of their cabs has a little video monitor at the back of the seat in front of you, where they're constantly running ads about one thing or another. You can't have that in your transportation. Now, I get questions like, well, can we have a video monitor that just gives advice to patients? If you have a video monitor in your van and all it's showing is videos on smoking cessation, basically here's how you do it, or on healthy eating habits or exercise, I think that's fine. If a part of that video is, oh, by the way, we have a smoking cessation class you can participate, then you got a problem. It can't be marketing or even informing the patient about any services that you provide. It can be providing general health information, but not any services. Otherwise, I mean, the government's just concerned that this is going to get out of hand and going to be used as a way to be a marketing tool, when what the government wants it to be is just a way for patients to access needed healthcare services. So just if you keep that focus or purpose in mind, I think that'll be helpful. They don't want, if it's just helping patients that need transportation to access medically necessary care, they're fine with that. If any part of it is used in advertising or marketing to patients or prospective patients, that's going to be a problem, and more than likely it's going to fall outside the safe harbor and outside the protection of the safe harbor. Let's see, I may have said some of this already. Providers cannot post signs, give patients pamphlets during transport. Yeah, that kind of goes along with the whole video concept. So you got to be very careful. Again, it shouldn't be marketing any services you provide. Any discussion of services that the patient should receive should come from the clinician, not the transportation provider. Transportation provider can talk about the weather. Transportation provider can talk about the transportation services and what's the easiest way to arrange it. So if Mrs. Jones or Mr. Jones needs transportation, they get this one and they're talking to the driver about, well, you know, this got me to this doctor's appointment, but I also have another doctor's appointment, or I have to go to the hospital for regular lab work. You know, the driver can talk about transportation options, but the driver can't be saying, oh, well, hey, you know, we don't take you to such and such hospital, but you can receive those same services at our hospital. Can't be doing that sort of stuff. And then again, the last bullet point, can't be a sales tool. I have had a question. Somebody asked me the last time I gave this presentation, they said, well, can we put up posters or put on our website that we're going to start offering transportation? And the answer is no. In my opinion, you can't, because you can't be advertising the services. It's not like it's some big state secret. But on the other hand, again, if you understand where CMS and the OIG is coming from and what they don't want it to be used for and how they don't want it to be used, I think you can understand you can't be advertising that. So if you're going to start providing transportation services, you need to have those conversations with the clinicians, with the offices, with the office managers. So you can certainly tell your office managers and your APPs and physicians that we are going to start offering transportation services to make sure that our patients have the ability to access medically necessary services. And then the clinicians and the offices have that information, and they can provide it to the patient if the patient needs it. So it may sound a little bit like splitting hairs here, but again, if you start with a focus of, well, is this making sure patients get needed services, or is this making sure we get new patients? What's your purpose behind it? If you stay with making sure the services or the patients get services, you're probably going to be safe. All right, Stark. I said at the beginning, the safe harbor is not a Stark exception. It doesn't address Stark. And of course, you know, just as a refresher, what Stark covers, Stark basically says that if a provider of designated health services, which would include lab, physical therapy, probably for our purposes, most importantly, inpatient and outpatient hospital services, if that's the case, that entity, the hospital, cannot have a financial relationship with the physician making referrals to the hospital. If there is a financial relationship, then the financial relationship needs to fall within one of the exceptions to the Stark statute. And you're probably all familiar with the various exceptions, some of which you use more than others. But Stark not only applies to the physician, but the immediate family member of a physician. And so if for some reason a physician, or more likely the immediate family member, like a parent of a physician, were to use the local transportation services, this safe harbor does not address the Stark issue that's just been created. So, you know, again, can't refer and the hospital can't bill if there's a financial relationship between the physician or an immediate family member of the physician and the hospital. What's a financial relationship? It's something of, if there's any remuneration of any type passing back and forth, doesn't matter which way it's going, then there's a financial relationship, and the hospital cannot bill for services it provides to patients referred or ordered by the physician if that relationship exists and it doesn't come within an exception. So what exception could possibly apply? Brian, the safe harbor doesn't apply. The only exception that really potentially applies would be the non-monetary compensation exception. In other words, pursuant to that exception, they can provide services. The transportation services could be provided to the parents or other immediate family members of a physician, so long as it falls within the non-monetary compensation exception. And kind of the key component, I mean, there's the requirement that the purpose cannot be related to the volume or value of referrals made by the physician. But probably the thing that's trickiest with regards to this exception is that there is a cap. There is a financial cap that was instituted when the exception was first created by rule, and then it gets adjusted each year for inflation. I think this year for 17, I think it's $378, if I'm remembering correctly. So you can, under Stark, use the non-monetary compensation exception if you're providing transportation to an immediate family member of a physician or a physician. I mean, it would apply to a physician as well. It just seems to be more likely that it's going to be a family member of the physician. So long as the value of that transportation does not exceed the cap on the non-monetary compensation exception, which again for 2017, I believe is $378. And so you can provide this transportation to a physician's parents, but you got to make sure that the value of that does not exceed $378 in this particular year. In 2018, it'll go up slightly. More than likely, it'll be adjusted for inflation. It'll go up slightly. So that's what makes it a little tricky. So we need to make sure that you probably ought to be reviewing your policy, or actually if you're creating a transportation arrangement and a transportation policy, you probably ought to be thinking about how do we track if we know it's an immediate family member of a physician. I think actually in rural areas where we have smaller numbers of medical staff, it's probably a little easier. Most people will probably know, you know, this is Dr. Smith's mother, this is Dr. Jones's father, or uncle, or something along those lines. And then we need to give some thought to how do we make sure we track the total amount of transportation being provided to this family member of the physician, and how do we know that, well, what are we going to do when we get to the cap? Maybe there won't need to be anything about it. The physician or the family member of the physician just uses the transportation once or twice a year, probably not going to go over the cap on the non-monetary compensation. On the other hand, if this person needs transportation twice a week, every week, well, then I think we got to seriously look at this. I don't think you can ignore this, because if you don't meet a stark exception, then all the referrals made by the family member, the physician that is this, whose family member receives these services, the physician can't refer to your facility, or more importantly, you can't bill for any services that are provided to patients that are ordered by that physician. So I don't know how much or how big of an issue this is going to be. I mean, this reg, Safe Harbor, only came into existence last December, and so you're just starting to see some of these transportation arrangements come into existence. But if you're thinking about doing one and you have some physicians on your staff that have elderly parents or others or other immediate family members that receive services from your facility, you probably ought to think about it if you need to think through that when it comes to providing those services for that immediate family member of the physician. See, that's so simple. That's why I kind of disagree with CMS and the OIG when they say it's a bright line. There's always, real life just always steps in and makes life complicated. HIPAA. HIPAA is also going to be implicated because, of course, patient name, address, telephone number is protected health information. So it's probably less of an issue if your facility, if you, let's just say, critical access hospital or rural PPS, it's not limited, obviously, to it's not limited to critical access hospitals. It can be any rural hospital, it can be any urban hospital can provide these transportation services. We recently were involved in putting together a transportation arrangement between Ascension Health and Lyft for all their facilities across the country. But local transportation in a rural area, you may just be using, instead of Lyft, you may just be using a van that you buy. Well, you have less of an issue there if the hospital actually is providing the transportation. It gets a little bit more complicated if you are using a Lyft or an Uber or a taxi company or other provider I include in this slide Liberty. Liberty is actually a Lyft or Uber type provider that functions in rural Missouri. And actually, I think they were just rolling out a new operation in rural Virginia. And so there are entities out there like Lyft and Uber, in this case, this one's named Liberty, that do provide those types of ride-sharing services. For those of you who may not be familiar with it, Lyft and Uber don't technically provide the service. All they do is provide the software and the connectivity. They connect a driver who wants to ride share or provide taxi-like services with individuals who need a ride. So they don't own the cabs like a taxi service would. They don't employ the drivers. They simply are a connection between somebody who needs a ride and somebody who's willing to use their car to provide a ride. And so we have a HIPAA issue here. We can certainly have a BAA between, and I'll single out Liberty because I know they function in rural areas. You could have a BAA between the hospital or the other provider. It could be, again, physician, any eligible entity, which is, I'm talking in terms most frequently of hospitals, but obviously it could be an RHC, FQHC, independent physician practice. Anybody who's going to provide those services, those transportation or arrangement services, and says, hey, I got a patient, this is their name, address, and phone number, will you provide them a ride, or let's schedule a ride, you're providing PHI to that entity, so you can have a BAA with Liberty, but then you need a sub-BAA with the driver because they're not an employee of the business associate. And so you have this situation. It's probably a little easier in smaller rural areas because you're going to have a lot fewer drivers, presumably, but you're still going to have drivers coming and going. And so you need to get a sub-BAA with each driver before they provide any services. I think that could be a little hard to do. It just may not be practical. So there are two options other than actual having BAAs with the drivers or sub-BAAs with the drivers if you use a system like Liberty or Uber or Lyft. You could actually qualify as a hybrid entity status. I don't like this approach generally because HIPAA provides that if you're a covered entity providing a non-covered function, meaning a function that doesn't trigger your covered entity status. So if one of the easiest things is like gift stores. I mean, gift stores is a non-covered function. HIPAA doesn't apply with that. And so technically you don't need to worry about HIPAA in your gift store. You could do the same thing if you're providing transportation services. The only thing I get uncomfortable here with is I worry that people lose track of, oh, I got to make sure I have a BAA when I do this and provide services, but not when I'm arranging for transportation. I just feel uncomfortable with that. You can do it. I'm not saying you necessarily shouldn't do it. It just is a lot more. You have to pay attention to the details and definitely would want to involve your legal counsel in that because you just need to make sure and do the training and make sure all your people know when you need a BAA and when you don't. I think the second option is probably simpler, and that's HIPAA authorizations. Obviously, if the patient signs an authorization saying you can give my name, address, phone number, and where I need to go as far as transportation. I need to go to the hospital for lab work. I need to go to this doctor or that doctor or the PT services. The patient can authorize that in writing. That's not going to be a big issue. you're already going to want to get a patient authorization for a release of liability. I mean, again, we're talking about transportation services that you're using a different driver. You probably still want authorization and waiver of liability if they're riding in your van, but if you're using Liberty or a group like Liberty or Uber to ride share, or you just you do that sort of function on your own. Hey, gee, we have a group of people out there who are willing to volunteer to do this. We're going to have them be our own hospital-sponsored Uber type service. We want to get a release of liability. If somebody, and I'll pick on Uber or Lyft, if an Uber driver picks up a patient and drives the car into the ditch and the patient gets hurt, we want to release the liability for the organization, for the covered entity, for the physician, RHC, FQHC, or hospital that arranged for that transportation. So we're going to want to have a form that has a release of liability. What I recommend is you just build a HIPAA authorization right into that form. So they say, yep, I understand this driver is not an employee or agent of the hospital, and if I get injured while riding in his or her car, I'm assuming that liability, and yes, I authorize the hospital or physician or clinic or FQHC to give my name, address, phone number, and other relevant PHI to the driver so he can pick me up and transport me. To me, that's the easiest way to address the HIPAA issue. We're going to want to get one of those from every patient before we provide ride services to them in the first place. So we deal with the HIPAA and the liability issue all at one time. Just talked about this. Dual purpose, yep, covers both the liability and the HIPAA. State law, and this is the last slide, and then we'll go ahead and take some questions if there are any. There is, not surprisingly, a state anti-kickback statute and a state Stark law. I don't think they really implicate ride sharing. I don't think is going to raise any significant risk under either the state anti-kickback statute or the state Stark law, so long as it falls within the requirements of the safe harbor. The safe harbor doesn't specifically provide a safe harbor from these state laws, but if it's within and meets the requirements of the state law, if it meets the requirements of the CMS OIG safe harbor that we've been talking about, I've never seen Michigan take any action against a provider if the arrangement fell within either an existing safe harbor or an exception. So even though we do have these state laws out there, at least in Michigan, I've never seen the Attorney General or anyone take any sort of action against any provider as long as they complied with a CMS, OIG, safe harbor, or exception. So with that kind of background, Victoria, maybe I'll toss it back to you to see if there are any questions.
Yep, I have two questions in the group chat. If you want to, I can read those out loud to you.
Yes, you don't mind.
Can we state that we transport to one location but not another?
In other words, I'm not sure I entirely understand, but I've taken the question to mean this. Can you tell patients we provide ride services to hospital A and Dr. B, but we will not provide services, we don't provide transportation to hospital X? And the answer is yes. Yeah, there's no obligation. If you're in an area where you're in a rural area and your 50-mile circle of being able to provide transportation overlaps another hospital in certain areas of the state, you might overlap more than one. within the 50 miles. And so can you say, well, yeah, this transportation service is being provided by Hospital A. We are not taking you to Hospital B or C that are also within the 50 miles. Yeah, that would be completely permissible to limit in that way.
And then another question says, our auxiliary has a fund that pays for rides home for patients that do not have a ride after discharge. Should we be having the patient sign a release?
I would tend to say yes. I would tend to say yes. I mean, if your foundation, and foundations, are they set up as part of the hospital or are they set up separately from the hospital? I don't think it really matters for the purposes of the question. If the foundation is arranging for services or arguably arranging for rides, they probably should be getting a release. I mean, if it's just going from home from the hospital on discharge to home, I don't think we have so much a PHI question, because the patient's making the decision to use that ride and they're providing their name and address, or at least their address. So I don't know that we have a huge PHI issue there. But even if it's just going from discharge at the hospital to home, if that driver gets in an accident and that patient is injured, yeah, I think it's important to have some sort of release of liability there, just to make sure the hospital doesn't get dragged into that lawsuit.
Okay. So those were the only 2 questions I had in the chat feature. So now I will unmute all the lines. So if you have any questions, you can go ahead and ask Brian now. So all the lines are unmuted, so you can feel free to ask a question. Questions or comments for Brian? Looks like you were really thorough, Brian.
All right. Well, good. Well, again, I want to thank you, Victoria, and thank the center for inviting me. And as always, if you do have any questions that come up, my contact information's there in the materials, so everybody can feel free to reach out with a question if something comes up later. Happy to help.
Yep, and also too, you can always feel free to reach out to us here at the center, and we can forward any questions that you have forward on to Brian as well. And you can also indicate them on your evaluation, and we can forward them on to Brian through there. We'll go ahead and sign off then if nobody has any other questions or comments for Brian.
Thank you, Victoria. Thank you, everyone.
Yep. Thank you.